Dear colleagues, I'm Michaël Ca from Leuven, and it's my great pleasure to be invited for this first virtual ISICEM meeting. Thank you very much for the invitation. I'm going to talk about the application of virtual reality in our burn ICU in Leuven. I have no conflict of interest for this talk. I'm very happy to receive funding from our university and for this particular project also from the Flemish government. I would also like to express my gratitude to our physiotherapists and occupational therapist team who contribute a lot to this clinical work and also contributed to this talk. I'm going to set the scene of early rehabilitation in the burn ICU and then explain the potential role of VR in it, and then our own new project on VR in the ICU. And of course, underline it's an integrated team approach from the start. What about early mobilization and physiotherapy in burns? It starts very early, day 0, and it goes on for more than 2 years. At the start, it's splinting and positioning of a patient, often in a coma, and respiratory therapy. Here you see a child with splints on the arm, and here a close-up of the splints on a hand and an arm. And then it goes on with passive joint mobilization, active joint mobilization, fighting the myofibrillous contraction in the wounds, which is not the same as muscle contractures, by passively stretching the wounds over the joints. And then thereafter, the patient starts collaborating in it by active joint mobilization. And sometimes when mobilization is difficult, we are very lucky to have our ergotherapists, as we call them, occupational therapy specialists, who try to find some way to make the patient, often children, start moving around as we like them to move. And then comes active mobilization out of the bed, logopedic interventions, as you can see here, a patient standing next to the bed, and then further in the healing, often behind or beyond the burn ICU, scar prevention and scar therapy, skills training, physical reconditioning. And it's all a team effort, with nurses, physiotherapists, occupational therapists, and of course the patient himself or herself doing all the best they can. The evidence behind this is still scarce, and our physiotherapists did a lot of work trying to find evidence and see where we can do better. The hardest evidence, the strongest evidence, is later on in scar prevention and scar therapy by pressure garments and silicone application. The evidence for the early interventions we do is much less strong, particularly in the early phase of mobilization of the joints. We only have some observational data. So despite 100 years of hard work and dedication, and at the bedside the impression of very good results and achievements, there's still a lot of work to do to have true RCTs exploring the best approach. This is one of the rare studies showing what is achieved in 74 burned patients. It burns 25% over 2 weeks in a burn ICU. And as you can see, most patients, even by the end of the 2nd week, still only have passive mobilization or active mobilization in the bed, and only a few of them achieve active marching around the bed, the lower, lighter colored markings. So measuring this is the first point, and then we have to ask, can we do better, and how should we do better? And there comes the burn ICU doctor's contribution. What can we do? Well, the first thing is to try to understand the process and try to facilitate it by adapting our approach to the evolution of the patient. And one of the main issues and the difficulties in active mobilization of these patients is having patients on the one hand, on the left, paralyzed by pain or fear, unable to move and unable to collaborate. And on the other hand, patients over-sedated by analgesia and sedatives, not able to collaborate. And that's why we invested over years in standardized assessment of pain and fear by the nurses, and also a protocolized nurse-driven treatment for pain and fear. In the beginning, we rely on strong and short-acting agents, and then as soon as possible, we simplify to oral or nasal application of analgesia and sedation. And now we also try, since a few months, the application of virtual reality. virtual reality with movies and music, and also suggestive talking, bringing patient into dissociation or even hypnosis. As you can see here on the right side, a whale swimming away in a cool sea. Of course, virtual reality is only one piece of the puzzle in non-pharmacological pain and fear relief. We also have mindfulness, biofeedback, music therapy, relaxation, watching movies, or electrical stimulation. And all of this has been studied by one of our psychologists in training. And these mechanisms, these techniques are relying on different mechanisms like negatory, distraction, dissociation, perceived self-control. And that's why we collaborate with Ronnie Briffards from the psychology department in studying these techniques. And in fact, we already know virtual reality is effective. Based on the published data, it seems to reduce the pain and the fear and to reduce the need for sedation and analgesia. Some studies also show a better passive range of motion upon mobilization of a joint by the physiotherapist. In one study, it even improved wound healing, but I don't know how it did that. But the studies are small. In total, there are less than 400 patients included, and many of these studies are not randomized. However, VR might be a true contribution going beyond the moment of the wound care itself. As patients are more relaxed, did receive less drugs, it's possible that during all the day they're able to are better in collaboration and to widen the distance between the patient being paralyzed by pain and fear and the patient being over-sedated all the day, resulting in a better rehab. And perhaps VR can do even more. Dissociation and hypnosis, true relaxation, self-control and breathing control, and as you can see on the left side, even techniques like assisted mirror therapy, which goes beyond our actual project. The main question is, in whom can this be applied? How many patients per year are true candidates for VR? And what logistics are needed? How many of these VR technologies needed for one 12-bed burn ICU? And how many collaborators for training patients into it? Particularly because in the ICU, we have the issue of multi-drug resistant organisms. So we cannot easily switch one VR tool from one patient to the other. In Belgium, we did survey the 6 burn centers in the context of the Belgian Burn Association and surveyed who thought there was room for improvement and need for VR. And in fact, all agreed that it would be very welcome, but lack of human resources and lack of time were the main constraints. And this was a study by another student of ours in psychology, Dr. Verkooyen. So now we're doing in Leuven a prospective screening of 15 months. And the primary goal is to determine the size and the characteristics of the target population for VR in the burn center. All patients admitted to the burn center who did require analgesia or sedation during the previous wound care are candidates for inclusion. And patients accepting to try VR and then successfully completing the procedure are considered a successful application. To recognize the good candidates and improve our understanding, we model a concentration of risk model, again with assistance of Professor Ronnie Briffards. And therefore, we collect data on the state-trait anxiety, depressive state, self-control, socioeconomic status, and the mechanisms of trauma. We also inquire patient and caregiver satisfaction. Do people get bored with this technique or not? And we try to estimate, even though it's not a randomized controlled setting, the potential impact of this intervention on drug requirements and experienced fear and pain as compared to conventional care. Which, of course, is a challenge because these patients should remain in their dissociated state, so we cannot use a visual analog pain score or this kind of stuff. That's why we rely on the FLEX score, the face, legs, activity, cry, and consolability score, where by simple observation, we can objectivate the pain and the fear of the patient during the intervention without disturbing. Thereafter, we inquire the self-reported experienced fear and pain by the patient post-procedure. We monitor heart rate and respiratory rate during the intervention. In a subgroup, we also monitor the range of motion during passive mobilization by the physiotherapist, and even the long-term follow-up is included in the program. And if possible, we broaden to the outpatient burn unit, include the pediatric ICU patients and patients from the emergency department. For this, we have a dedicated research nurse and psychologist having the time to explain and prepare the intervention the day before the wound care, quiet in the room. We have for every burn ICU bed one headset to avoid the problem of drug-resistant microorganisms. And all this thanks to the Flanders region government supporting this study, making us independent from the company providing or selling these materials. So we hope that this study will provide a sound basis for future investments in burn units in Belgium and abroad, to know how much material, and how much human resources are needed for adequate application, based on a true field of application, how many patients are really candidates for this technique. And also to estimate the impact on patient well-being, on recovery, and on health economy, which may help to inspire hospital directions, health insurance, and governmental funding into continuing these efforts. But of course, VR will always be only one piece in the puzzle of dedicated burn teamwork. The most important thing will always be to be dynamic, to communicate, and to do good planning day by day. A daily planning of anesthesia and sedation and wound care, taking into account need for passive mobilization and active physiotherapy, need for first time out of bed with doctor nearby, the timing of eating, having a nap or playing, also decided by the patient herself or himself, timing of hospital, school, and ergotherapy interventions, patients being awake when the psychologist comes along, and sometimes patients requiring a day off, a calm day. All this should be taken into account. So I conclude that early mobilization and broader physiotherapy are the cornerstone of burn care. And virtual reality can play a major role in improving the well-being and in enhancing rehabilitation. But VR will always be just one piece of the puzzle, and this will remain teamwork luckily from day zero on. And therefore, I would like to thank all my colleagues from the burn unit and all my co-investigators in this project, in particular Professor van den Bergen, Hannah and Kathleen, our research collaborators, Professor Ronnie Bufferts, Lise Mebis, and my colleague MD Renate Hagedorn. Thank you very much.